Good evening, hello, and welcome to everybody, and thank you for joining us for this evening's Facebook Live. My name is Alec, I'm the MD of Wound Care People. This evening's session is brought to you in partnership with the Legs Matter Coalition, and we're really pleased to be doing this because I know for a fact that this evening's session is going to be very thought-provoking. We'd like you to ask lots and lots of questions. And tonight we're joined by the wonderful Alison Hopkins, who's the Chief Executive of Accelerate, and Dr. Leanne Atkin, a Vascular Nurse Consultant from Yorks NHS Trust. Ladies, are you there?
Hello.
Hello. How are you, Leanne? Are you well?
Yes, I'm good, thank you. Thank you so much to Wound Care today for helping us host this, really, and having this awkward conversation, as we're going to call it.
No problem. And yourself, Alison, how are you?
I'm very well, thank you. I'm excited always to have a good discussion about leg ulcers and compression. So well, I'm hoping to challenge your questions.
Thank you. Sorry, I didn't mean to interrupt. I know that in the build-up to this, we've done a couple of polls, so we'll be discussing the results of those. For all of you who are watching, certificates will be available for attendance to prove your attendance at the end of the event. Please send in as many questions as you can, and we'll come back after the discussion between Alison and Leanne to answer as many of those as you can. Some other members of the Legs Matter Coalition have joined us this evening. They'll be answering some of the questions directly in the comments section. So if you do get a response from them, then feel free to have a conversation direct in there. Without further ado, I'm going to leave it to you two ladies. So I know that you're chomping at the bit to get cracking on this conversation. So over to you. I'll see you at the end for the live Q&A.
Thank you very much. So I'm going to be starting off this section. And so I'm Alison, and I have a long background in tissue viability and in community nursing. So this is a particular passion of mine, and it's also a great honour to have a conversation with Leanne about these issues. And so we really do hope that it will generate questions and challenge to us. So the features of this session are that we're going to be looking at the role of Legs Matter as a campaigning coalition. And we're going to point out how we think we're challenging the status quo around leg ulcer management. We're going to be talking about our role in delivering the National Wound Care Strategy and how all of us can support that. We're going to draw on the beliefs that we hold around leg ulcers and compression therapy in particular, and we're going to be challenging some of these assumptions from which our behaviour is based. And hopefully what we'll be doing is looking at how we can create change for this marginalised group of people. So Legs Matter has a tagline called Reshaping Care Together. And what we mean by that is it is a joint coalition between clinicians, societies and our patients, and we have three particularly skilled people who come with experience of leg ulcers and lymphedema to the group, and it's a very exciting place to be as a clinician. So why Legs Matter? Why do legs matter? Why Legs Matter as a coalition? Well, about 3 years ago, a group of senior clinicians got together, and we recognised actually that harm was occurring for people with leg ulcers, that people weren't necessarily listening, and that we knew that enough was enough. And I suppose also because of the seniority that we had, the experience of probably at least 20 years each, we came with confidence to this discussion, and we were able to be bold in saying it as it is. And we had used all means up to this date to prod and complain about leg ulcers being marginalised, being second fiddle really to pressure ulcers a few years ago. And we were challenged to speak out about this. And I suppose as a group, we were able to come together and have boldness actually as a group where we were of the same mind. And we didn't feel the need to be politically correct about this, that we felt that we could be bold and challenging in the way we spoke, and the words we used. And the other thing about the Legs Matter Coalition is that we wanted to maintain our independence. And so whilst each of us are coming from a society, and we're under the auspices of the Tissue Viability Society within their governance structure, we were able to maintain our independent voice and to not be swallowed up by maybe NHS England and other trusts where it's very difficult sometimes to actually speak your mind. So we knew that we needed to create change. We know that the burden on patients and community nurses in particular is enormous. It's really significant. And of course, we know that there's data coming out about the growing number of wounds and the growing amount of activity associated with community nursing. So we looked at how we could really clarify the solution, and we wanted to have a patient-facing campaign. We recognised that actually over 20 years of leg ulcer management owned by clinicians hadn't created the change that was needed, that more education, more of the same wasn't going to create the change that patients actually needed. So our solution as a campaigning group was to raise public awareness, and we've done that through working out how we can create greater knowledge for our patients about their conditions and how they can be better advocates for themselves and to have better conversations with their GPs and nurses, and also to have greater expectations actually about what they should be having, what they need to have as a patient requiring more complex care than they're having. And of course, we are working very much alongside the National Wound Care Strategy, and we're helping to steer that in the right direction as well. So when we talk about leg ulcers, we probably know as clinicians on this call, we know what we're talking about. But often commissioners or even directors of nursing may actually not know what we're talking about. But what we see in leg ulcers is that the correct care that patients need is just incredibly effective. But the problem is they're not getting it. So when you look at the leg on the left-hand side of your screen, you will see that you had someone with terrible cellulitis, repeated lymphorrhea. They had repeated admissions, about 3 within 6 months. And what they needed was really good compression therapy to affect the change that you can see there on the lower picture. But the thing is, you know as well as I do, that lymphedema, if you use that term, often people say, oh, well, we're not commissioned to deliver lymphedema care now. So people like this fall through the net, even though you can imagine having a leg like that yourself, you would be wanting to have the correct treatment. The leg in the middle was a gentleman who was basically tall, and so the standard care was ineffective for him. And so you can see that he had a very nasty inflamed ulcer for several years, and basically simple, high, strong compression made the difference. And the last gentleman, again, was quite large, and standard care, in effect, had failed him, but it wasn't necessarily the treatment. It was the lack of consistency that he had. And you can see that his leg looked rather worrying on the top picture, but was very straightforwardly managed through, again, strong compression. But he needed consistent care. And I have to say that the gentleman in the middle and on the right had been given the label of being non-compliant. So we're a campaigning group. Legs Matter is a campaigning group. That's our focus. It isn't actually education of nurses. What we're trying to do is draw attention to the fact that what's happening isn't good enough, and that we're actually focusing on patients, their relatives, families and friends to create the change needed. And so in our most recent campaigning week in October, we had 42 live events, lots of things around mobility, about compression, Pilates, lots of different things. And they're all on catch up. So you can go to the website and have a look. And so from a campaigning organisation, our Twitter feed, the hits on the website, the articles in local newspapers, it's all on the rise. And we've done really well this year, despite COVID and the workload that all the coalition members have had. And this is Derwent TVN team with their pink flamingos, who are rather fantastic. And so it's not just us that get involved. And so on the website, if you're not familiar with the website, please do look. We have some fantastic downloadable information leaflets. Here's one on hemosiderin, a common question: why are my legs stained and reddy brown? And there's some recent new information leaflets, one on pyoderma gangrenosum, very nasty ulceration, and sickle cell disease, less known, but for those of you that work within inner cities will be more familiar with sickle cell ulceration. So these are all downloadable, and we're welcome to have any comments on these things. So working with the National Wound Care Strategy is very important. I think I might be right in saying that all of the coalition are involved in some way, shape or form in the lower limb group within the National Wound Care Strategy. And so we bring our independent thought as well as our the expertise of our societies to the National Wound Care Strategy. And we have been able to bring patients into the discussion and decision making. And I suppose one of the things that we spend quite a lot of time on is how we support the rollout of these ideas that are coming through the National Wound Care Strategy, and how we as a coalition challenge the system and prod it in the right direction. Two of the key ways in which we've supported this is, again, through the lower limb group. And the role of ankle brachial pressure index has been challenged. So for those of you that are not aware, there are new guidelines that have just been launched, I think last week or the week before, around the intervention of mild compression without ABPI being done. And so please do familiarise yourself with these new guidelines. And we've been at the forefront of this challenge because we see that the issue of ABPI, if you haven't got it done, you can't apply compression, is really part of risk aversion rather than risk management for this group. And we would say that we need to acknowledge that this creates delays, and these delays are not warranted. And so jointly with the British Lymphology Society, we agree that the risk of no compression outweighs the risk of non-treatment, because that's what we're saying is happening. And also that if mild compression is successful, then there are going to be many patients for whom they don't actually need to go on to have a full assessment of an ABPI. So I've mentioned mild compression, and so this strategy advocates the use of mild compression on all lower limb wounds where critical ischemia has been managed and risk managed. And we can put on mild compression in the form of class 1 socks or class 3A type bandages. And basically, we are hoping as a coalition that this stops the default position of the use of crate bandaging as being first line. And this allows early treatment, effective treatment, and it will allow a percentage of patients, we don't know how many, that will not need to go on to full assessment with an ABPI, that there will be stopping of some deterioration for many that go into a complex path of ulceration. So the other thing that we've been doing is looking at changing our language. So we use words like therapeutic intervention instead of just compression. We're trying to discuss the level of potency required, and that we need to choose the level of potency required for this amazing intervention. And so whilst I've mentioned mild compression, we mustn't stop at mild compression. We need to ramp it up. And the exciting two little words that are in the guidelines from the National Wound Care Strategy is that compression, when you've assessed properly and then non-healing with mild compression, is that the patient needs to have receipt of at least 40 millimeters of mercury pressure. That at least was very important to us because it recognizes that 40 millimeters of mercury is not the top, is not the scary heights of compression, that some people need strong compression. And here you have just a little explanation there from the World Union of Wound Healing Societies principles of best practice for compression therapy. And it's something that you may want to look up. So why do we need courage to compress? We know that compression is the treatment. There is no new study that needs to tell us that. We know it's the treatment. But the trouble is that for every presentation around compression, you may have the fear of the amputation story that goes along with that. And so there is a culture of risk aversion. And there is, alongside that, the lack of recognition of harm and a lack of ownership around soggy legs, and even a culture of acceptance. And where's the patient's role in all of this? I would suggest, before we look at the patient's role and the critique around compliance or non-concordance, is that we need to get our house in order first. We need to have a better dialogue with our patients and with our colleagues. And we need to, firstly, have massive amount of belief and confidence in this amazing compression. And if we don't have that, then we're not able to have the good conversations with our patients around treatment that's difficult to tolerate. So we need to challenge ourselves better, and we need to look at the system change that's required. And Leanne will talk about this as well. So is change in the hard box? Only if we let it. And we need to use more of our common sense, and that needs courage in our system, in our hierarchy in nursing. And we need to have courage to use compression alongside risk management and brilliant documentation as to the rationale for its use. And we need to look harm in the face. We need to recognize that a soggy leg, excoriated limbs, dripping, painful ulcers that are changed twice a day is actually not necessary, and is actually harm that we as a system are not tackling. So we need to stop walking by. We need to be advocates for change. And I would say to all of you that are online that are willing to really take on board some of this challenge that we're bringing today, is that have courage, because the tide is turning. That 10 years ago we couldn't have talked about harm because people would not recognize it. Leanne and I were probably doing this 10 years ago and it wasn't recognized, and people were like tut-tutting because it seemed rude. We need to listen carefully to the language that's used about our patients, actually, and we need to call it out. And we need to watch out for a culture of acceptance that's in our midst. And ask simply, for the patients that you see tomorrow, is why are they in crepe? And so we need to recognise the controls in our system. This is about you and us. We need to, if we want to bring change, we have to actually believe it's possible. If you don't believe it's possible, then you won't see change. We can't also blame others, and we need to identify what structures or beliefs are holding us back. And fundamentally, if we want to learn as clinicians, we need to work with patients in partnership, and then we can wrestle the control away from systems to real people and to make a difference. So at that point, I'm going to be handing over to Leanne. Thank you very much. Put questions in the Q&A. Thank you.
Hi. Thank you, Alison, who beautifully set the scene about what Legs Matters is trying to do, and really trying to set that little worm inside your brain to really ask yourself, how are you practicing? How are you treating patients with leg ulcer in your daily practice? And how do you know you're getting it right? So my session really is to make you think. It's to make you reflect. And I'm going to really start to focus on your individual perception of compression. So let's just recap where we are across the UK. Well, in terms of lower limb care, it's recognised that we've got unwarranted and unwanted variation in practice. We have huge problems with poor assessment and the timeliness of that assessment. And the National Wound Care Strategy is challenging you that with all patients from time to referral to time to holistic assessment, including that ABPI, and even going beyond the ABPI if it's above 1.3, then actually that's done within 2 weeks of wounding. And I can imagine many of you will gasp and say that's not possible. Well, it is possible if we start to think of things differently. We really need to make sure, like Alison said, that we have the evidence based and we are using it in everyday practice. And that evidence is 40 milligrams of mercury at least for venous leg ulcers, and venous intervention to eliminate the underlying cause through vascular referral and vascular intervention. And we really need to challenge directly the ineffective therapies. Anybody with a venous leg ulcer in reduced compression, light compression, double K light compression, really needs to be challenged, because that's not effective compression. It is ineffective therapies. You are causing harm, you are elongating patient suffering. And we really need to question, why is the systems designed like they are? In terms of, you see one practitioner who only can do part of it, but you need another referral and another time delay to get to that other practitioner. And maybe your policies dictate that if it's out of these scopes, I have to refer it on to a specialist nurse. Why are the systems designed around the movement of the patient rather than the patient in the heart of our systems? And what does this result in? Well, it results in healing rates that you could cry about. This Julian Guest paper shocked me to my core. And the reason for that is that he showed that we're achieving 47% healing rates for simple venous leg ulcers at 12 months. I can show you a number of randomized control studies, just the simple control arm. In other words, those receiving standardized care. We can get healing at 86% at 24 weeks. Why can, when we control the care, why is that so different to the reality of what we've got? And if I show you these pictures of all of these wounds, I'm sure many of you as clinicians out there will look at these pictures and you will be able to recognise some of the patients that you are caring for regularly. And some of these will be your problem patients, in terms of they will be the ones that requiring at least daily dressings 4 times a week, compression therapy, and maybe some of these has been labelled as non-compliant. I just challenge you to think for one thing. Every single one of those chronic wounds that you see started off as a small, simple wound. We missed the boat. The NHS caused these chronic ulcers. We caused the harm. If we'd have got it right first time, 95% of those patients will have been healed within 12 weeks. What have we done to ourselves, to the service, and to our patients? We need to think about this. And please do not get me wrong. This is not about us bashing the nurses out there. We know in your heart you do the best job possible. It's about actually changing the culture. And to change the culture, we have to ask these challenging questions. We have to set these little mealworms inside your brain, really questioning, why do we do things like that? Is that the best for the patient? Legs Matters is all about supporting the nurses, and I will support any nurse because I truly believe you're in there to do the right job. But we need to have these difficult conversations. We need to shake the ground if ever we're going to make a difference. So we set 5 questions online through the help of Wound Care Today. And we ran this through a number of their social media sites and their website platforms. And we asked for responses to 5 simple questions. And over the week that this survey went out, we got 53 replies. So I just want to go through these and actually talk about the results that we've got. So the first question was simply asking, what do you feel is the biggest barrier to effective compression therapy? And these are the results. It's really interesting to me that nobody chose that we had inadequate guidelines. In other words, we all know what we should be doing. There's no uncertainty regarding leg ulceration. In fact, with leg ulceration, we should be very grateful, because I would argue it's the only thing in nursing that we have level 1 evidence of we know how to treat this. Many other aspects of nursing, we do not know the answer to that question. But if you look at these responses to this, it's really interesting that 43% of you acknowledged that there is delays in assessment. And yes, we appreciate those delays will be because of staffing issues, because of how it's derived within your local policy. But is that good enough that 43% of you recognise that there is an inherent delay in the way that your services have been set up? If this were your own business and you recognise that 43% was just waiting, would you change your services? And I appreciate that many of you out there may have been trying to do this with your line managers. And don't worry, we're having these conversations with all tiers of nursing, right up to the directors of nursing, because we need to change the narrative of leg ulceration throughout the whole of nursing. But I'm just going to bring Alison into this conversation now with us, because I'd just like to say, to ask Alison her opinion really of, Alison, 30% of the responders to this survey thought the biggest barrier to compression therapy was actually the patient views on non-compliance. What do you think of that?
So it's an interesting one, isn't it? Because this is the thing, if you have a roundtable discussion, this is the thing that pops up all the time. It's the biggest issue that people will spend their time talking about. Yet we've also recognised that there is an inadequate skill, an inadequate system, yet 30% would say actually this is the patient's fault. And I suppose the question I would ask is, at which point, when you've got poor care, delays in the system, inconsistent care, at which point is the patient allowed to say, my treatment isn't working and I'm not happy? And I don't think that's allowed. They would be honestly termed non-compliant, that if the bandaging has been put on badly or incorrectly, that is considered, again, if they took it off because it was too painful at the ankle or rode up at the Achilles heel, they would be called non-compliant, because that's what happens. And the other thing I would just say is when we were talking about this in Legs Matters, it was a real surprise to patients on this group that this is the story. They would be shocked, actually, I have to say, if there are any patients, I don't know if anyone patients in the background here, that actually there's a big discussion all the time about poor compliance. And I think we've got to get over ourselves and look to ourselves first before we label people. I'm not saying it doesn't happen, but I'm saying it doesn't happen 30% of the time.
It certainly feels like a throwaway excuse, doesn't it, at times? You know, yeah. Especially the patients that we get referred, oh, it's because they're non-compliant. Yes. And it's interesting that, you know, I'm not saying 100% of my patients are in full therapeutic compression, but I don't call them non-compliant. I call them my challengers, but a lot of patients that are labelled of non-compliant will actually wear full therapeutic compression if you give them the information of why they need it, the choice in terms of how we can deliver it, and that they feel confident with the practitioner that they're dealing with. Yeah. And I'm with you. I think a lot of this comes by the system, how it's been set up, of the inconsistency, that you see so many different individuals, whereas if you have your named nurse, you do develop relationships with that. And, you know, again, all of this is possible, isn't it? And I do think that we need to relook at the way that our adult community nurses staff deal with these more challenging patients. And I think that that's where the registered nurse is needed. I'm a great believer in non-registered nurses applying any form of compression. But for the challenging patients, we need the skills of the registered nurse, and we need the consistency and the investment and the relationship to be built up. So it's just really interesting that when we asked what's the biggest barrier, first is the system, second is the patient. There is a little bit of response on there in terms of clinical skill. And yes, that's something that we need to embrace and improve on from the NHS. But just reflect on the fact that a third of you who responded to this blamed the patient first. Is that something that we should really reflect on and digest and challenge when we use that word of non-compliance or non-concordance? So the second question we asked you, and I said that some of this is going to be difficult to hear, and please, we welcome any challenging questions. We're asking challenging questions as you have an audience, please post them to us. You know, we're happy to take on that challenge that you want to give us. So the second thing that we asked you in terms of a question is, we asked you, how do you think you provide assurance that you are applying effective care to your patients with venous leg ulceration? And this one made me and Alison chuckle, I can tell you that. Okay, so a large proportion of you, 90% of you, said the way that you assure yourself that you are applying good therapeutic levels of compression is by monitoring healing rates. I can tell you that you're lying to us, because you might think that that's the best effective way, and I believe it's the best effective way. Well, me and Alison know of 8 organisations across the whole of the UK, Scotland, Wales and England that are measuring healing rates currently. If you actually ask your organisation tomorrow where you work, what's our healing rates? How many patients do we get healed at 12 weeks, 16 weeks, 24 weeks? They will not be able to tell you. And it's interesting that you, like us, believe that that actually is your best measure of quality, effective care, but you're actually not doing that. Alison, we like the idea of patient feedback, obviously, that they're part of that. What do you think of using Datex or prescribing data in terms of proving effectiveness?
I think Datex is not generally used within leg ulcer management at all, and I would welcome people completing Datex reports for delays. We've already said that there are a lot of delays in clinical assessments. So the question is, how do we, within the governance structure in which we work, highlight where there are delays in effective delivery of care? We know it's happening, but people generally don't do that for Datex. So just reflect on how pressure ulcers are managed through Datex versus leg ulcers. And the other thing I'd say about healing rates, I mean, I do recognise it was a bit of a cheeky question, really, because no one knows. But we can, as clinicians, we're in our own little bubble. Because we know the person that we've been managing is healing, great, right? And that's lovely, but it doesn't actually necessarily inform us about the organisation. And so what we know from various audits that we've undertaken and, of course, published data is that healing rates aren't recorded. No one actually knows. And directors nursing don't know, because I've had that conversation recently. And the governance structure, the CCG doesn't ask for that data. So no one asks, so no one gets. And so I would challenge us to not just look at the healing rates within maybe a leg ulcer clinic, but across the system, from the practice nurse to the leg ulcer clinics to the care in the home. And it's absolutely variable and mostly not recorded at all.
And in terms of prescribing data, actually, we found through the work that we've done with NHS England rather than Legs Matters that actually those that spend the most on compression therapy through prescribing have the better service. But it's interesting that you'll find that the compression budget goes up, but the wound care budget goes down.
Yes.
Because you actually manage them effectively. And especially, I know that Accelerate's got some fantastic data directly relating to full strength compression and superabsorbance. Because if you get the full strength compression on, you'll get the leg dry.
Yes, so the data around dressing prescribing, I love it, actually, absolutely. Anyone that knows me knows that I love digging into data. And so what you're looking for to tell a story about whether care is effective or not is in the superabsorbance or the high use of crepe. So not looking at spend, because spend on a compression bandage is, $350 to $10 if it's a kit or whatever, versus ATP for a crepe bandage. So what we're looking for is number of units used. And then you're looking at the superabsorbance or the antimicrobial use. And then you're looking at the very large ones, because the 20 by 40 centimeter dressings are the ones that are only really ever used for legs. They're not for an abdominal wound or a chest wound or anything, it's legs. And so if you know where to look, you can see where the costs attributed to poor lower leg care is residing.
So the third question that we asked is, do you believe that you can apply compression, full therapeutic compression, without an ABPI? And a third of you believe that that's possible, which actually is great, because if we would have asked that question 5 years ago, it'd probably only be 5-10%. So it's great to see that the tide is turning, but at the same time, it still tells us that we've got a phenomenal amount of work to do, because 2/3 of you say that you shouldn't apply compression without an ABPI. So Alison's already talked that the National Wound Care Strategy has already given you permission to apply 20 milligrams of mercury pressure at the ankle, simply by excluding the red flags. No ABPI, no foot palpation, no auscultation of Doppler tones. It is simply no red flags. You can apply 20 milligrams of mercury. But when we think about 40 milligrams of mercury, an ABPI cannot be the only key to the door. What if a patient can't lay flat? What if the patient's got too big a limbs to get round a cuff? What if you haven't got the right size Doppler probe, so you can't actually auscultate the arterial tones underneath it? So does that mean those patients will always be in that state because we can't do our official ABPI? One of the best documents I've read all decade is the BLS document, the position statement on ABPI. And I urge you all to download it, have a read of it, because it gives you the sense check of what we need. If the leg is huge and congested and weeping and showing signs of venous disease, compress them. The chances of you going to do some harm to that patient is really small. In fact, minuscule. We have more and more education and research from a vascular perspective that we're using full strength compression in ABPIs of below 0.5 in specialised hands, and with good success. We need to move away from the fact that we think that this compression is going to be harmful for the patients. That's often due to poor bandage technique, not to do with limb perfusion itself. So we really need to challenge this ABPI. I can hear you all screaming at me now saying, but it's in my policy. It may be, but maybe tomorrow you can have a conversation with your service leaders to say, why is that in my policy? Why can't we change that? Why can't we adopt the BLS statements? Why can't we move with the times of changing that way of thinking? Because patients, not every patient can have the same key to the door. And finally, we went on to talk to you about what do you believe is the highest amount of compression you can apply? And we asked the simple question of, do you believe 40 milligrams of mercury is the highest pressure compression that you could apply? And we nearly had a 50-50 split of this. I must say, probably only 2-3 years ago, I thought 40 was it. I thought that that was good practice. I thought that that was, we got there, the panacea of where we need to be. But actually, as Alison's shown, Europeans would call that mild to moderate compression. They use 60, 70, 80, and with appropriate effective care. Alison, you often talk about tailoring the dose of compression to a patient, and I love that narrative. And me and you know about the anti-inflammatory properties of that very potent device called compression. And we use analogies of dosing when you're taking aspirins, or what requirement do you need? Can you just give us some explanation of why does it need to be individualized, and what type of patients are more likely to need a higher level of compression?
The level of potency that compression is required for the patient there's, I suppose, the key areas that you need to think about would be the height of the person. The taller they are, the more like a giraffe they are, the further their venous return. And so they seem to need to have the 40 to 60 millimeters of mercury in short stretch terms for this compression therapy. If they're very wide, of course, as well, as you've already said, so I won't elaborate on that. And the other thing is around the extent of their venous disease. So in post-thrombotic syndrome, they definitely need higher compression. I'm sure someone that's got compression of about 30 millimeters of mercury, it just won't touch the sides, So we've got to think more creatively and think about the person in front of us, and whether, if the compression from mild to moderate is not working, then what are you going to do about it? That's it. How are you going to ramp it up? And there are ways of doing that and of seeking help for that. And if someone says that's all there is, do not listen to them, because what you're saying is that there is no plan B for that patient, that they are stuck with their life. And that's actually not correct.
So when you say about post-thrombotic syndrome, that's a syndrome that happens after patients had a deep vein thrombosis. And that's because the deep venous system has been affected, so becomes incompetent. The majority of patients with venous disease, you've got superficial venous incompetence, so can be successfully managed with a normal or a lower level of compression, such as 40. I think one of the greatest things that Alison ever told me was, if the leg is wet, it needs more compression. And if you just think of that for a moment, of course it does, because you're not getting rid of the internal pressure that's pushing the fluid out. So if the leg is still wet and highly exuding, you really need to consider, do I need to step up my level of compression? So I'm just going to press on with the questions, because I do want some time to answer some questions that's come in. And the final question we asked yourself is, do you believe that all staff caring for people with leg ulcers have the correct skill and knowledge? And the majority of you said sometimes as the answer. A lot of you recognise often not. And only a small proportion of you said, yes, we have every time. Do you think this is one of the reasons why patients may fall into that non-compliant group? If they're not being treated, if you don't believe as a clinical workforce that we have a skilled workforce so that every patient is being treated by a skilled individual, can you understand how patients start to lose faith in us and what we're doing, and that relationship starts to break down? We need to be proud of the services that we do, and we need to challenge this directly. I appreciate the restrictions of CPD, time to study and all the rest of it, but that needs to be directly challenged. We need to be going to our governing bodies, to NHS England, to say we need protected time for our education, for our competence, because we want to deliver a good service. And that's all part of the Legs Matters narrative. We are trying to campaign for the rights to nursing education at the highest level, because we really believe if we had an enabled educators workforce, we would get better patient outcomes. So I urge you all, if you just think of one thing from the end of this, please start seeing venous leg ulcers as a weed. All you're seeing is the dandelion's head when you're looking at that wound. The roots of that weed is within the venous system. You need to think about, how are you reducing that pressure on that venous system? And is the amount of pressure you're delivering therapeutic? And there's some easy wins. Have you got limb volume reduction? You're on a winner. Is the wound bed exudate levels reducing? You're on a winner. Is the signs of infection or increased localized infection reducing? you're on a winner. If your patients are saying, my pain's got better, you're on a winner. Because every patient who's got significant pain, once the therapeutic effect of compression kicks in, the pain will start to decrease because you're eliminating the underlying cause. We all need to get this right. We need to get this right for us as nurses, for the NHS, but we need to get this right really for the patients that we serve. I'd like to introduce you to Tracy. She's now a member of the Legs Matters board and she's a patient of mine. I'd like to just read her words of the impact of what having a leg ulcer and living with a leg ulcer has been like for her. She simply says, I'm upset about the life I could have had, the career I should have had, and the person I should have been. I always thought I'd be somebody and achieve something in life, but I feel I've had this opportunity stolen away. I hate feeling self-conscious, disabled, unattractive. I hate that this leg ulcer has taken away my self-confidence. And that's the reason why Legs Matters exist. We want to break that status quo. We want to demand better care for our patients. Please, I urge you all to read the new recommendations from the National Lower Limb Stream. They're going to be posted on the feed for you to click on. It's a fantastic resource. It is the future. It is going to help break down the barriers that we've discussed. So I just want to leave you all really with a bit of a call to action. Stop your own personal apathy in this space. Challenge it. Be that voice. Be that voice for your patients. Start to yourself seeing the world differently. It doesn't have to be this way just because the system has made it this way. We want you to really consider how the system thinks, how the system works from a patient's point of view, what the reality is truthfully to the patients that you served. There is so many easy solutions to this, solutions that will really help to improve. We are producing a call to action document. It's going to be published in January. It's going to be focused at clinicians, patients, and politicians. We are going to try to really give this narrative to all levels to try to force that change. When we did our first awareness week, one of the members of our nursing force within the NHS sent us this picture. Her name was Laura Kay. I found her fantastic and I was amazed of how incredibly talented a lot of our nurses are in terms of artistic flair. But I look at this picture and it brings it home to me. It brings it home of what we're doing and how we need to do things differently. So thank you for listening to this challenge. There is a downloadable certificate for you, courtesy of Wound Care Today. But we have left 15 minutes to be able to have some conversations with you, to hopefully answer some of your questions, to be able to give us a challenge back. So, Alec, over to you to ask us some questions.
Thank you, Leanne, and thank you, Alison. It's a fantastic presentation as always. Just from reading the comments, I've been following the comments through, and there's been certainly lots of challenging questions and lots of conversation taking place. So, so thank you again very much. Just one comment from me, and that was when you were talking about the survey that we put out. And you did say you were going to be very harsh. Question 2, when we were asking about the healing rate data as a measure of effectiveness, I thought maybe we should have asked the question as to whether they thought that it was, because I thought that the individuals were answering on their behalf, and I feel like as though really we probably should have asked whether trusts or whether their organisations they work for measured.
No, I think I left that question purposely broad and unambiguous to be relatively evil, because
it was evil.
I think we all recognize. But the truth of the matter is, Alec, is that most of the audience recognise that healing rates is the panacea.
Yeah.
So how are we allowing them not to be documented? So just because the organisation doesn't do it, why aren't we challenging that?
No, I get that, but Alison, you actually touched on when you jumped in with your response to Leanne. I think you answered what I was thinking, which is that from an individual basis, if you're a district nurse or a community nurse and you're answering that survey, and the question is how do you measure success, then you're looking at what your caseload is, and perhaps you're not looking at it from a macro level as to what's going on within your trust or your CCG. You're looking at the 50 patients that you've got to see in a week. And your measure of success is healing rates for those. It's not about certain data or prescribing information. It's, am I personally healing those wounds?
Absolutely.
Yeah,
and we all do that in terms of that's our individual sense check, if you like. But there's no evidence of that. There's no data to prove that.
I guess that then takes it back to what you were saying, and I don't want to dwell too much on this, but perhaps there just needs to be more sort of upward reporting from everyone who has a patient caseload, upward reporting, so that you get that sort of mass data for each trust.
The issue, Alex, is just to add to this, is that those who are enthusiastic, that are on here tonight, they may well be collecting something, right? But the thing is, we don't as a whole. And so that variation is not known, it's not seen, and actually healing rate data from an objective sense, not just the 5 that we know about, but the 50 that we don't, is not known. And whilst that's happening, we don't know our healing rates.
So just to ask you a question then, just to stay on this topic, I would imagine that lots of trusts do collect data, whether they do it well or accurately or not. There will be, we have to assume that some are collecting data, because I've seen some data.
No, don't assume that. It's absolutely
okay, fine. So we won't assume it. Does that mean then there's an opportunity for Legs Matter to help individuals collect their own data, or is that sort of a step too far, getting involved in what trusts are doing? If an individual watching tonight wanted support to be able to collect their own data, to feedback to their manager, to feedback somewhere else, is there any sort of standardized reporting toolkit that they can access to be able to keep it and then present it to their team leader, to their manager, to their...
This is the problem, Alex. We don't even know how to measure healing rates, my dear. And this is one of the fundamental problems that we've challenged the National Wound Care Strategy to answer. Is it from the point of wounding to the point of healing, as in full epithelialization, or is it the point of referral into the service to full epithelialization? Because if there's a delay of getting that patient into your service, your healing rates might look very good, but they're not. Does Legs Matter do that? No, we don't. We are focused on changing the status quo. Do me and Alison do that as individuals? Yes, we do. Would we be prepared to share our tools with the audience? Of course we would. And I believe, like Alison, the people that's watching this, in a way, isn't the right audience, because you're already engaged, you've already got a love, you're already investing your time. But I do think that people here would be really welcome their own healing data. To see, oh God, I healed him within so many weeks and so many weeks. I do think that's a way of
encouraging.
Providing individual feedback that, do you know what, I'm a junior staff nurse and I'm trying to shape the wider narrative, but I'm finding it difficult. But me as an individual, I know I'm doing a really good job because of this data.
Yeah, okay. We're going to move on because we've had lots and lots of questions, and you can probably see that my dog is making a bit of a racket there. So this is showing that we are actually live. Look. So the first question we've got is from Simon, and he says, and I'll ask this to you first, Leanne, just so that we know who's going to answer. How can I change GPs and district nurses' reluctance to complete Doppler exams and prescribe compression products in residents of nursing homes? I feel like I'm shouting, but no one is listening.
Okay, there is some very easy tools for you now. Go onto the National Wound Care Strategy website. Within that, you will see a page. It's called the First Tranche Application. Within that, there is a health economic model and a business case. You show that to any of your commissioners. It has been approved by NHS England. It's a tiny investment for a massive gain. Gain on workforce, gain on direct cost, gain on patient harm. And it also shows that you get an 11% reduction for acute hospitalisation. Your commissioners, your nursing homes will be interested in that data, because we don't want anybody going into a hospital at this moment in time. So it's about a fantastic individual being known. Where do I go for my ammunition? And the ammunition is there on the National Wound Care Strategy site.
Okay, and links to, we've mentioned this a couple of times, links to the National Wound Care Strategy documents will be available via this site and via the comments section, and also with the edited version of the video on our website from tomorrow. So question 2, I'll ask this to you, Alison. Some patients will not wear compression stockings because they're too tight. Is there a minimum level of tightness that a patient could tolerate that would still be effective?
Goodness, I mean, there isn't a minimum or a maximum, really. It's what works for the patient. So what I would say is, what does tight mean? And that just needs to be, you need to dig into that with the patient. And then you could maybe layer it up. One of the easy ways of getting compression socks on is having a liner sock plus maybe a class 1 flatbed hosiery or elasticated hosiery, and building it up that way. We don't have to have all the compression in a class 3. We can layer it. You may be able to use a liner with a wrap. Basically, you've got tools, and mixing and matching with those tools are the important thing for me with hosiery, and understanding where it's digging in. If it's digging in, why would you wouldn't wear it? So I wouldn't either.
Yeah, absolutely.
And it's about really educating that patient of the reason why the compression is needed. And just because one compression garment hasn't been successful for them, doesn't mean they can never wear another compression garment. How many times, I'm a larger lady, how many times have I bought tights? I couldn't wear them. They're all down me fat belly. That don't mean I'm non-compliant with tights. I've just bought the wrong pair. I need a different brand, a different pull-up. But this is the reality. We all shop in different places. So do they need a wider top so it's not going to dig in? Do they need a stiffer fabric so it's not going to crease within the ankle crease? So it's about not giving up because they've not worn it once and they're taking it off. It's about getting back to the conversations, the narratives of why, and the options that we've got for treatment.
Yeah. Question 3, this is from Tracy to you, Alison. If legs are wet, I understood that this needs to be dry before compression. Is this right?
Wow, I have no idea where that one came from. Never heard about that. So that's an urban myth that has taken me by surprise. No, you basically, compression is an anti-inflammatory property that you're putting on the leg, and it will address the leakage and the edema and the wetness. It's coming from somewhere. It's either coming from a wound or through pores and it's just weeping. And compression will target that and dry it out very fast, depending on what the issue is. I would also say that elevation can't be forgotten about, and elevation, making sure that people see getting their legs up, not just sort of down, but sort of up, is part of treatment. And just to have some rest in the afternoon with treatment and see it as treatment rest, sort of hospital at home type thing, stop them going into hospital, would be an important one as well. But compression basically stops the dripping. It's quite straightforward.
Excellent. And I think you touched on that as well in the presentation. So we'll we've got loads of questions. So if it's all right with you two, we're just going to stay on for just a couple of minutes longer than the 8:30.
We'll try and be short.
Yeah. So question 4, this is from Samantha. So the National Wound Care Strategy Programme recommends that mild compression should be applied as immediate and necessary treatment unless patients have red flag symptoms. A red flag symptom is acute or chronic limb-threatening ischemia. How is this defined? Leanne?
The easiest way is the wound on the foot. If you're a novice in this, if it's on a leg, put 20 milligrams of mercury pressure on it. Critical limb ischemia or limb-threatening ischemia is the same terminology. If you can remember when COPD changed to or COAD changed to COPD, we're just changing it from critical limb ischemia to limb-threatening ischemia, same thing. Remember how limb-threatening ischemia presents? It presents with a sunset red foot that diminishes on elevation. It presents with terrible pain that the patient will say, I could chop my own leg off. And if it presents with a wound, the wound will be on the foot, most predominantly on the toes, sometimes on the heel. But if you've got an absence of those, then you can go into 20 milligrams of mercury pressure. Watch out again on the National Wound Care Strategy. They're going to be delivering you some podcast type education about how to recognise each of the red flags. And we're more than happy to come back to do a session for Wound Care today, an actual education focus piece on about how you implement the National Wound Care Strategy, looking at that.
Okay. So we've got one more from Alison, and this to you, Alison. Could you clarify what you mean by full strength compression? I feel there is a difference between what our trust recommends for use of compression bandages and what the manufacturer recommends for technique of application from a newly qualified nurse.
What a great question.
Yeah, can I just clarify? So what I think I'm hearing is that full strength compression, it depends what the guidelines are or the formulary, what product you're using. So there are some products where the maximum that will be applied is 40 simply because of the product itself. So I'm reluctant to name products in this sort of session, but there are some products where you can layer it to get more compression and you're increasing the potency that way. And I've forgotten what the question was.
Is there a
Leanne,
difference between what the trust recommends for use of compression bandages and what the manufacturer?
So there will be. So we know that trust guidelines are pretty poor across the UK because they reflect the NICE guidelines or the RCN guidelines before that, and they're pretty useless, to be honest. And so they're very bland. There's only, you put this on, if it doesn't work, you take it off. Right? That has no alternative plan for the patient in front of you. So we recognise that the guidelines aren't really very helpful, and they probably have either reduced compression, which we're like trying to call mild, or moderate compression, which is in the UK considered high compression, but it isn't. It's moderate compression.
But I'd take my hat off to that newly qualified nurse for actually knowing the pressures that her bandage gives.
Yes.
You know, if we all understood the pressures that the systems that we use gives, we'd all be one step further forward than what we are. We need to really directly challenge in that, and the National Wound Care Strategy will help that in terms of, we're saying it's 40 milligrams of mercury. So if you're using a type of system with a greater ankle circumference, you're going to need 2 layers of that certain system. You know, we really need to be changing. If your formally only stocks reduced compression or light compression, you're elongating suffering, you're elongating spend, and you are creating patient harm. But Alison's right, the problem is it's all bedded down within local policy that hasn't been updated for donkey's years. We renew policy every 2 years in the NHS. We don't. We just go through it and update the references and put out the same stuff year upon year upon year.
Okay. So for the two of you, this is from Lizzie. This is there a way to signpost patients and or family to Legs Matter?
Yes, just simply click. Yeah. Do a contact us. We'll send you a whole pack. You will have packs in terms of to go posters on walls. You can give you some business cards, so you can give it out to every single patient. You can also, as well, all of the leaflets that Alison pointed out in the presentation, you can all just download them as a PDF and print them locally. Anything that's on our website, pinch, use, utilise, and we can even send you some glossy material for your clinics too.
Yeah, can I just say as well, with regard to sort of the previous question as well about the different what manufacturers are recommending, you've obviously got commercial partners, sort of industry partners who support Legs Matter, and their information is available with links via your website. So they'll all have information about their individual products. So all of that is available directly via the website. And when you're downloading your certificate, and a link should be available, or a link should be visible on your screen at the moment. When you're downloading your certificate this evening, at the bottom there's a consent option for GDPR which says, would you like your information shared with Legs Matter? And if you click on that, we will share your information with Legs Matter, and then they can contact you to send you some of this information. So all the things that that Leanne was just mentioning.
And just to say, industry isn't the baddie in this relationship. You know, industry is the goodie in this relationship. Industry wants you to use their products responsibly and appropriately. I've never met one company that wants you to use it unethically or inappropriately. The baddie in this is the NHS systems that we're working in, and that's what we need to challenge. industry are fantastic at providing good levels of education.
Yeah, I would agree with that as an ex-industry person. So I think that's it for tonight. What I will say is there's obviously lots of questions that have come through that we haven't had a chance to answer. So what we're going to do tomorrow morning is we're going to download all of the comments and all of the questions that have come through. We will share that with the Legs Matter Coalition. They will have an opportunity to reply to those questions individually. What we'll then do is we'll create a document which we'll put online as a PDF. So you'll be able to come onto our website, rewatch the video at any time, share it with any of your colleagues that perhaps didn't get to see it, and you'll see the Q&A sheet on there with any of the questions that were asked tonight that didn't get an answer. So we will get back to you. Just unfortunately, we've run out of time this evening. Leanne, Alison, it's been a pleasure to work with you as always. Thank you very much for your passion, really, and your enthusiasm. It's very obvious that not only, and I know this is very obvious, not only do you know what you are talking about, but you clearly have a real keen passion for it, and that certainly excites me. And I'm sure, just judging by the comments from the people who have been watching this evening, your passion has come across, and I know that they've really enjoyed watching the presentation with us also. So we'll be back with Legs Matter Coalition at some point soon. Thank you everybody for joining us. As I said, links for everything that we've mentioned this evening should be available on your screen now, along with a link to download your certificate. Don't forget to press that button and we'll share your information with Legs Matter for them to send you some information. Have a good evening. We're back on Thursday with another Facebook Live, and then we have a JCN Live, which is 3 days of non-stop evenings of Facebook events next week, Monday, Tuesday and Wednesday. So do look out on our Facebook pages for those. I'll be back, I think I'm back on Thursday doing another one of these. So if you join us then, I'll see you then. Ladies, enjoy the rest of your evening.
Thank you.
Thank you very much for joining us, and good night.
Thanks very much.